Hi, welcome back. This is Dr. Praveen Tirlangi, and today we'll be discussing about the basics of invasive mechanical ventilation. This session is going to be a little bit basic, so if you think that you are already an expert, probably you can skip this basics of invasive mechanical ventilation. This is primarily targeted to MD medicine residents or respiratory therapists who are just trying to play with the ventilators. Today, we will try to understand the basic ventilator language. So, when you enter the ICU, there is a lot of jargon, and for you to understand that, you should understand the basic ventilator language. We'll also look into interpretation of curves in mechanical ventilators, and we'll also discuss about different modes of mechanical ventilation. This is a very common question by the residents: which mode to use. The question itself is wrong. It doesn't matter which mode you are using, provided you understand it. And troubleshoot common bedside ventilatory scenarios. So again, being as a resident, I also had this problem. So when you're listening to someone teaching mechanical ventilation, how to do a ventilatory settings in ARDS, it all sounds very nice. But the moment you go bedside, something changes. You won't be that comfortable. You feel like you are not able to apply the knowledge bedside. So we'll discuss about the reasons for that and how to really bring the knowledge of invasive mechanical ventilation bedside. So most of the times we use invasive mechanical ventilation for indications like hypoxemia, acute respiratory distress syndrome with type 1 respiratory failure, sometimes COPD patients with acute exacerbation, community acquired pneumonia. We also use invasive mechanical ventilation to protect the airway in the patients who are obstinate because of CNS infections with hydrocephalus or people who are having some neurological disorders. So, we initially use the invasive mechanical ventilation for these patients to prevent aspiration. Sometimes for threatened airway, rarely patients can present with poisoning or toxin related indications like opioids, which can cause obtunded sensorium. And commonly, we also use invasive mechanical ventilation in a post operative period. So, the difference in a positive pressure ventilation and spontaneous breathing we have to understand. In spontaneous breathing, we are creating a negative intrathoracic pressure by the contraction of diaphragm, and the chest will expand. So basically, you are not compressing the pulmonary vessels in this process. So there is a good VQ matching. So the alveoli which are getting ventilated are getting perfused also. Positive pressure ventilation is actually opposite. So this is not a normal physiology. What we are doing in positive pressure ventilation is we are pushing air into the lung with a positive pressure during inspiration. That is definitely going to compress some of the alveolar capillaries, which creates sort of dead space. So this dead space makes it very difficult to wash out the CO2. So the minute ventilation required in positive pressure invasive mechanical ventilation will be little higher. So usually we look at least 100 ml per kg ideal body weight. So for someone is having 60 kg ideal body weight, the minute ventilation will be at least 6 liters. If something less than 6 liters, we are expecting patient might retain CO2 eventually. So let us look into the ventilator circuit. So this is how it looks. There will be a ventilator with a interface, user interface. So there are two limbs, inspiratory limb and expiratory limb. So from the inspiratory limb, the air will go to the patient, and from expiratory limb, it will go back to the ventilator into the atmosphere. So in the inspiratory limb, you can have an active humidifier. Most of the times we are not using active humidifier anymore. Most of the it adds a lot of dead space. So with except for the rare indications where secretions are very thick, we usually use something called HME. HME converts the moisture heat in the expiration into the moisture, and that will help in humidifying the patient's airway. And usually in expiratory limb we'll have a filter, and there will be an expiratory sensor also here. We will look into the function of this sensor. This is very important. So if you are having a ventilator which is continuously giving alarm of failure of expiratory flow sensor, that is a problem, because all the numbers you are seeing on the ventilator is derived from this expiratory flow sensor. So let us understand a little bit about the terminology. So mode of ventilation is basically a prescription which we give for the patient. Routinely we use pressure control ventilation or volume control ventilation in initially for the patient, and when we are trying to wean the patient we will switch him to pressure support ventilation. So these are the three most common modes of ventilation, and if you master them you will be able to manage any patient. There are few other modes of ventilation like a PRVC, then APRV, airway pressure release ventilation, and adaptive supportive ventilation. If you learn them, it is good, but they are not mandatory. And if you understand VCV, PCV properly, it is not difficult to understand the other modes of ventilation also. So our focus will be very basic. We'll be discussing more about volume control and pressure control. So previously we used to call it as CMV, controlled mandatory ventilation modes, but in modern ventilations we don't have a controlled mandatory ventilation. We always have assist control. So assist control can have VCV or PCV. There used to be another mode called synchronized intermittent mandatory ventilation, and this is again we don't use anymore in the ICUs. Modern ICUs you won't see patients on SIMV mode for reasons which we will discuss eventually. And there is something called control variables. For example, if they are putting the patient on volume control ventilation, the control variable is volume. Basically, we are trying to give some volume. For example, in VCV, you have put a tidal volume of 400 ml. So the ventilator will try to give the tidal volume of 400 ml. So volume will be a control variable there. In PCV, you will set a pressure till which the ventilator will keep giving the air. So if you set a pressure of 20, for example, that will be the control variable. Trigger is very important in assist control ventilation. So basically what you are doing in assist control ventilation is you are allowing the patient to take that effort initially, and if the patient is able to take that effort, that is the time where ventilator is going to give a breath. So this is well synchronized. So the moment patient tries to take a breath, the ventilator will deliver a breath. So just because you have set a respiratory rate of 20, that doesn't mean that patient will be breathing at 20. So if patient is having high respiratory drive, he's triggering 30 times a minute. So the ventilator will give 30 breaths per minute. So that is one of the problem where in initially patients with ARDS with high respiratory drive, how to manage them. That is what we are going to discuss today. What about cycling? So cycling is where the inspiration will switch to expiration. And what about the breathing patterns, whether it is mandatory? Mandatory breathing you can only see in patients who are heavily sedated and paralyzed. Spontaneous breathing, we are expecting it in a pressure support ventilation when we are trying to wean the patient. And assisted breath types are the most common in VCV and PCV modes is what you are going to see. So in volume control ventilation, we discussed that we'll set a tidal volume. So we tend to say that in a logical way, when we try to understand volume control ventilation, we think that if you set a patient a volume of 400 ml, so the ventilator is going to deliver 400 ml no matter what. That's a wrong understanding. Most of the modern ventilators are actually dual ventilators, and if you see a ventilator, you will see that you can put a alarm settings. So in volume control ventilation, what we do is we put a alarm for pressure. So the P peak pressure around 40 or P low probably around 10 or whatever. So the moment when you're delivering this 400 ml of tidal volume which you have set, the moment the pressure goes more than 40, the flow of the flow will decrease to adjust to that pressure. So basically it is not like just because you have kept a tidal volume of 400, the ventilator is going to give 400 irrespective of pressure. The moment it reaches that pressure which you have set in alarm, it will not deliver in anymore. So that is the reason why when you go to bedside and you see many times you see you have set a tidal volume of 360, but patient pressures are going high, so the volumes are not getting delivered. Just because you have put a volume control ventilation, it will not burst the lung open, right? So in volume control ventilation, again you have a variable peak pressure, that is understandable. And what we set in volume control ventilation usually is the flow rate. So basically we'll set a flow of 60 liters per minute. That is what we usually start, but you can play between 40 to 60. The moment you increase the flow in volume control, the airway pressure is going to increase. So that is something which you have to understand. The inspiratory in pressure control ventilation, we adjust IE ratios. Basically, it is the same thing: high flow, is equal to less inspiratory time. So if you are decreasing inspiratory time, the flow will be high. So some of the ventilators actually, even in pressure control, even in volume control, they give an option to adjust the IE ratios rather than adjusting the flow. Both are same thing, doesn't matter. And in volume control ventilation, there could be a risk of pressure trauma, and in pressure control ventilation we'll switch we'll put a upper limit of pressure. So if the compliance is very very bad, a patient can have a low volumes delivering to the patient. So actually patient can eventually have a CO2 retention. So monitoring is more important in both volume control and pressure control, but you have to keep seeing that what is happening. So there is no mode of ventilation where you can say that you don't have to monitor the patient. And if you are monitoring the patient properly, the volume control or pressure control doesn't really matter except for very rare situations. So usually so when we are talking about assist control ventilation, we have to set a trigger. Trigger is nothing but the effort which is taken by the patient, so that ventilator can detect that effort and give the breath. So that is a perfect synchronized ventilation. So actually the assist control, volume control and pressure control should be called as uh, uh, synchronized ventilation rather than SIMV mode. So you can set either a flow trigger or pressure trigger. It doesn't really matter. So usually we keep around -1 to -3 of flow or of pressure or flow of 1 to 3 liters per minute. So if this is the pressure which is generated by the patient, the ventilator is going to deliver a breath. Or this is the volume if the patient is sucking in, the ventilator is going to deliver a breath. So if you keep a trigger very low, even small changes in the circuit or small leak which is there can keep triggering the patient. So this can lead to auto triggering. So you have kept a respiratory rate of 20, but there is some fluid in the circuit which is moving, which is oscillating a little bit, creating some negative pressure, and the patient is getting breaths around 60 or 70 per minute. Sometimes even in cases with aortic regurgitation, with a very high diastolic runoff and high pulse pressure, even that movements of the chest can trigger ventilator sometimes, even though it is rare, can happen sometimes. And it is important not to set the trigger again very high also, because patient will try to breathe, but he is not able to reach that trigger. Um, uh, so there will be very high work of breathing, and that. So basically, during my residency, I have uh, seen a senior resident doing a magic. So he was basically teaching the other residents that, see, this patient is having a lot of asynchrony. I'm going to set it right. So he increased the trigger to -10, and suddenly all the ventilator curves started looking normal, and everyone is in awe. So God knows how difficult it was for the patient to breathe, to trigger. So you do not increase the trigger sensitivity to achieve synchrony. You don't treat the ventilator curves, you treat the patient. Very rarely, probably in patients with bronchopleural fistula, there is a continuous leak, and that is a leak which you know. Probably you want to keep the trigger a little bit high, but not in the range of -10. So this is how the triggering happens. So this is the patient side. This is the inspiratory limb, and patient is taking. So basically, whatever flow we are giving from inspiratory limb will also go to the expiratory limb, and there will be expiratory flow sensor, right? So the patient takes a breath, tries to take a breath, and he creates a negative pressure, a flow here, that can lead to a decrease in flow or pressure reached in the expiratory flow sensor, which ventilator senses this, and it starts giving a breath for that patient. So this is how assist control ventilation actually works. What about cycling? When will the inspiration will become expiration? In pressure control, usually we'll set a time, inspiratory time. In volume control, again, when the volume has completely, whatever volume you have put, if it's completely delivered, the ventilator will switch from inspiration to expiration. In pressure support ventilation, where the patient is breathing spontaneously, we usually set a setting where the patient's maximum peak inspiratory flow will drop to some extent, usually around 25 to 35% of peak expiratory flow rate. That is where we switch the patient to from inspiration to expiration. So among the VCV, PCV, and pressure support ventilation, uh, the cycling usually happens mandatorily in pressure control and volume control, and cycling will depend upon the peak flow rate uh, uh, in pressure support ventilation. In mechanical ventilation, as we discussed, some of the breaths are could be mandatory. Mandatory breaths will usually happen when the patient doesn't is not triggering. Could be reason could be heavy sedation or neuromuscular blockage. And assisted ventilation is when the patient is able to trigger a little bit, but still in a assist control VCV and PCV. And in pressure support ventilation, most of the times ventilator will only support the patient's breath, so patient has to trigger. You have to adjust the trigger sensitivity, and once the patient triggers, the ventilator will support the patient's breath by giving some pressure. So that is pressure support ventilation, which we are using in patients where the ventilator requirements have come down and you are planning to wean the patient. That is the time when you switch the patient to pressure support ventilation. So you can see three curves here. So usually we'll have a pressure, volume, and pressure by time, volume, flow by time, and volume by time curves. We are not showing volume by time here. You can see that this patient, there is no inspiratory effort, unlike this patient where there is an inspiratory dip in the pressure. So there the patient is trying to take a breath, and the ventilator has given the breath. So this is the assist control mode. This is where the patient is not at all trying to take a breath, probably because of heavy sedation or neuromuscular paralysis. And this is again patient is trying to take a breath. You can see the cycling also here. This is a volume control ventilation, and you can see that cycling happened after some time. And here also you can see, but here you can see that the inspiratory flow time is not reaching the zero before it is switching to expiratory, because the ventilator we have set at 25% of the flow. So this is the peak expiratory flow, and the flow when drops to 25% of it, it will switch to expiratory cycle of the respiration. So this is the pressure support ventilation, and this is the assist control ventilation with volume control, and this is again volume control. You can also see there is a plateau here. This is because of the setting of inspiratory pause in the ventilator. Usually we do inspiratory pause to assess the P plat and P peak. P peak will be getting once you put an inspiratory pause. You can actually measure the P plat. P plat indicates the lung compliance. So basically, when you decrease the flow, when you make the flow zero, the airway pressure will become zero. So total pressure is airway pressure plus lung compliance. What is the alveolar pressure? So once you make the airway pressure zero, what you're measuring is the alveolar pressure, which is nothing but P plat. We'll be discussing more about this. So we have discussed about the assist control and mandatory ventilation and SAMV. So SAMV is again very interesting, which we'll look into. So in volume control ventilation, you see this is again pressure time, flow time, and volume time curves here. So in volume control, whatever you have set is going to get delivered. So among these three, volume time is little less important. We'll be more interesting into the pressure time or flow time. But if you ask me, only one curve which you really want to see is always flow time. So if you are going into the ICU and in volume control ventilation, you are seeing only volume time but not the other two, then it's a problem. Probably no one is looking into it, right? So the flow time curve will give a lot of information as well as the pressure time. For example, in this patient, you can see that there is a constant flow pattern, then there is a inspiration has switched to expiration, and this is where expiration has completed. But then you can see that there is a small uh, uh, dip in the flow during expiration, and you can also see that there is a small dip in the pressure post expiration. It looks like the patient is trying to take an extra inspiratory effort. So what happened here is basically patient wants more inspiratory time, but you are not giving that much of inspiratory time. So this is called cycling asynchrony. So probably you're looking by looking at it, you know that it's probably cycling asynchrony, and probably you have to increase the inspiratory time. That you can do that by decreasing the flow in the volume control ventilation. Very similar to cycling asynchrony is another asynchrony called reverse asynchrony. This could be reverse asynchrony actually, because you can see this kind of same wave pattern after each breath. Reverse asynchrony is nothing but it's a diaphragmatic contraction because of the volume we deliver. So when the patient is very deeply sedated, it is more like a reflex of the diaphragm. So once the patient is very deeply sedated, and you give a volume through the ventilator, it will lead to the contraction of diaphragm, and that can sometimes lead to actually severe asynchrony, but that's called reverse asynchrony. There is no way you can just see the curves and differentiate between cycling asynchrony and reverse asynchrony unless you have a esophageal pressure monitor where you can actually see the diaphragmatic contraction, right? So this is the pressure controlled ventilation. Here you can again see the pressure, flow and volume. Here the flow and volume is what we are really interested in. Pressure we know what it will be, right? So what you can see here is it's a decelerating flow pattern with there is a peak expiratory flow here and everything is good. So uh, you have put a pressure control 20 above PEEP. PEEP is 5, so PEEP flat will be 25 and the peak pressure is also 25, so the airway pressure is almost zero in this patient. But if you look at into the driving pressure is 20, so this itself is injurious to the lung. So we want to target a driving pressure of less than 50 in these patients. What about SAMB, which we are discussing a lot? So basically in SAMB, what happens is the ventilator will give intermittent mandatory ventilation. For example, you have set a respiratory rate of 20. So one breath in every 3 seconds. The ventilator will give one breath in every 3 seconds, irrespective of whether patient is taking breaths in between or not, which doesn't happen in ACMV. So in SAMB, for example, you have set 20 breaths. So 20 breaths will be delivered. On top of that, patient can extra take volumes in between. So for example, you are giving a mandatory breaths of 400 ml, just suppose, and the patient takes in between 200 ml. And whenever the patient's effort and the mandatory ventilation come together, both these volumes will be synchronized. So basically, you'll get three different types of volumes: 400 ml when the ventilator is getting giving mandatory breaths, 200 ml when the patient is having spontaneous effort, and 600 ml when the patient's breath is getting synchronized with ventilatory breath. So this is problematic because the 600 ml is going to cause ventilator induced lung injury. High tidal volumes will also cause diaphragmatic dysfunction, and now even the neuronal signal will be a little bit confused. So whether the patient is having high respiratory or low respiratory of the brain will be confused. So this is the worst way you would want to wean a patient. So this will require to sometimes respiratory alkalosis, especially if you are saying that you want to use it for patients in neurological issues. That is a bad idea. In neurological issues, you really want to have a strict control of what is the PaCO2 in the blood. So excessive washout or retention will be problem, and because of this, there will be a lot of asynchrony. The use of sedation will go high. So that is exactly reason why it should be called as asynchronized intermittent mandatory ventilation rather than SAMV. So that's exactly why we don't use SAMV mode in routine ICUs. But if someone is using this in modern ICU, that means only one thing, that they didn't really understood what is SAMV and they are a little bit confused. So we have discussed a lot in theory. This is what happens, but when you go to the bedside, you'll have an issue. So let us try to apply our knowledge to a real bedside scenario. So this is the 18-year-old female with fever, dyspnea. She was diagnosed as malaria and ARDS. So basically, she is having a very bad PF ratios of less than 150, and patient is breathing at 30 per minute. She is tachypneic, and when you saw the X-ray, there are bilateral lung infiltrates. So we all know how to set initial ventilatory settings. You want to use uh, low tidal volume ventilation, something between 4 to 8 ml of ideal body weight, usually 60 ml per kg of ideal body weight. You want to set a respiratory rate so that she will not retain a lot of CO2. So baseline, if patient is very tachypneic, probably you want to start around that respiratory rate, not more than 30. You start with a higher FiO2, then you can always come down. You start with a PEEP using probably ARDS net PEEP table and then adjust it. So ARDS net PEEP table is one of the very primitive way uh, to adjust the PEEP. So you don't strictly follow ARDS net protocol. You have to look into the driving pressures and adjust. That is one way of doing it. But using ARDS net protocol strictly without actually looking into the lung compliance, what is the recruitability of the lung, will actually can be really harmful. This is one of the way where people still use ARDS net protocol. Uh, but it is not very scientific anymore after 2 decades from what we used to do. Then we want to put a PEEP. So how to adjust PEEP is a big question. There are many ways, many limitations for each method. But right now, the most easiest is the best one, because in bedside you should not be doing a lot of, because whenever patient is admitted in critical illness, it is not just ventilator which you are looking into. There are many things: airway, breathing, circulation, diet, electrolytes, fluids, glycemic control, then fever, the infection risk, the liver functions, kidney functions, the cardiac risk of cardiac arrhythmias, the catheters, the risk of venous thromboembolism, risk of bed sore, the nutritional status of the patient, and sedation, analgesia, neuromuscular paralysis. There are a hell lot of things besides the actual diagnosis why the patient is admitted in the ICU. Sometimes it could be a diagnostic dilemma. So you need a lot of time to manage the patient. So it is always good to do things which are very focused, which are objective and easy to do, rather than doing something where you cannot actually validate from others. So if you are doing something and someone else is doing, and both of you are having a different interpretation of the same thing, so subjectivity is the problem. So PEEP also, there are a lot of methods. You can do a lot of stuff to really understand how to adjust the PEEP, but bedside, looking into the driving pressures is probably most scientific, shown to decrease the mortality when compared to looking at plateau pressures alone. So that is what we have to do bedside. But again, when you're looking into the driving pressures, you should know that patient should not be having a high respiratory effort. So if patient is taking a deep breath inside, the driving pressures will no more reflect transpulmonary pressures. So basically, we are looking at driving pressures as a surrogate for transpulmonary pressures. Then we want to set a IE ratio. Most of the times we use an IE ratio of 1 is to 2. Sometimes in patients with airway hyperreactivity or autopip, we need a little bit of higher IE ratios in these patients. So you can increase the expiratory time by increasing the flow rate so that the inspiratory time will drop, or by decreasing the time in IE ratios. But one has to understand that the moment you decrease the inspiratory time, the flow is going to increase. And if the flow is going to increase, the airway resistance is going to increase. So the treatment of bronchospasm is not increasing the expiratory time, it is the treatment of bronchospasm. That's why we keep saying that we don't treat ventilatory flow curves, we treat the patient, right? Prone position is very important for this patient. So there is a Prosiva trial which is published in 2014, if I am not wrong, which is associated with a mortality benefit, and that is the standard of care in the ICUs. So if you see a patient with PF ratios of less than 150, and if you prone the patient within first 24 hours, at least 16 hours per day, that will be associated with mortality benefit. So once you are proning the patient, basically you are improving the VQ mismatch. So once you prone the patients, the perfusion to the ventilation to the posterior aspects of the lung which are well perfused will increase, so VQ mismatch will improve, and also the pressure which is created by the heart and pericardial structures will come down on that part of lung, so the ventilation of that part is also going to improve. um, uh, this we can actually see with examples. Humans are actually evolved from four-legged animals that we keep saying when we prone. It's a good example, funny though. So prone position is definitely something which is required. So when we are discussing this, it looks like very smooth, right? So what is the problem? The problem is someone who is hypoxic, someone who is not able to breathe, and before coming to the hospital, patient is hypoxic for hours, and then you want, if I make you run for a kilometer or 2 kilometers, then you ask you to breathe, you will take a very deep breaths, and you'll be tachypnic. At the same time, you'll probably take this position. This is nothing but a prone position. This is how we try to improve our VQ mismatch, which has come naturally to us. So that is what you are going to do, and suddenly now you want to protect the lung from patient self-inflicted lung injury, and you want the patient to take tidal volume of 6 ml per ideal kg body weight. He is not going to take. He is going to have a bad respiratory effort. So we sometimes it could be just because of the anxiety or air hunger. So if you give a little bit of FiO2 oxygen to the patient and give an analgesia, probably a little bit of sedation, many of these patients can have a decreased respiratory drive where you're able to manage. 6 ml per kg ideal body weight, but sometimes the respiratory drive can be seriously high, especially in patients who are also having acidosis, where you have to kind of take control of the ventilation. So those are the patients where you'll require a deep sedation, which we don't want to do, but sometimes you have to do a deep sedation. And sometimes these patients you might require a neuromuscular blockage, especially in the first 48 hours of the severe ARDS patient. You might need the patients to, you might have to use neuromuscular blockers, and we always ensure that the patient is deeply sedated to a RAS score of at least -4 before giving neuromuscular agents, right? So this is how it will be. Like, you have kept the patient on volume control ventilation, and you are expecting that the patient will be happy the moment you put the patient on ventilator and volume. And this is what you see. You see that the patient is breathing very rapidly, and these curves are looking very crazy. So this is a classical flow asynchrony. So basically, this is the pressure curve, and you can see that there is a dip in the pressure during inspiration itself. This is happening because the patient wants more flow. Okay, so either flow or volume is what you have to increase. You cannot increase the volume, so you can increase the flow in volume control ventilation. So this is the flow asynchrony. Patient requires more flow than what you are giving, and you can increase the flow. You can see actually a little bit of flow asynchrony on many of the patients. In this patient it is gross. Sometimes if the inspiratory effort is too much, more than the trigger you have set, it can lead to uh, double trigger. Like, you can see breath stacking, one breath on top of another, which can be injurious to the lung. But if it is a mild flow asynchrony, you don't have to worry about it. You know it will settle eventually when the patient's ventilation is improved. So again, you don't treat all the ventilator graphs which you are seeing. You see that there is some flow asynchrony. If it is significant, you have to obviously do the needful. But if it is not significant, not really causing any problem, you can just wait and watch. But you should know that there is some amount of flow asynchrony. Same is the problem in pressure control, because in pressure control we set the inspiratory time. So the patient might want to have a longer inspiration than what you are giving. In this patient, you can see that there is an effort immediately after inspiration. So this is because whatever the inspiratory time you are giving is not sufficient. Patient wants a longer inspiratory time, and this is called cycling asynchrony. So you have to increase the inspiratory time. Cycling asynchrony and reverse asynchrony, we have discussed about the reverse asynchrony. So it is very similar to a deep tendon reflexes. If there is a no control of brain over the tendons, and you tap the tendon, it will contract. Very similarly, there is a deep sedation, no control of brain or diaphragm, and you tap the diaphragm giving tidal volume, it will contract. If it contracts very strongly to trigger a breath, it can lead to breath stacking. So that's called reverse asynchrony. But the setting in which you see reverse asynchrony, you always know that reverse asynchrony is going to happen in patients who are deeply sedated, not the patients who are not deeply sedated. And what you can see is, you can see the same pattern in all the breaths. So that is one of the clue that this is unlikely be cycling asynchrony rather than it is a reverse asynchrony. So in asynchronies, the three most important, in fact it is two most important asynchronies one has to understand, and which are very logical, which are very easy, are flow asynchrony, cycling asynchrony. If you know about reverse asynchrony, it's very good. We always talk about double trigger. Double trigger happens because of the cycling and flow asynchrony, right? So it's not a separate asynchrony. Basically, whenever patient is having asynchrony, and the asynchrony is so much, for example the flow asynchrony is so much, that the patient is able to trigger, they create a negative pressure or whatever trigger sensitive had kept, there will be delivery of another breath. You can see that the tidal volume you have set is 350, and patient is receiving 700, double trigger. But what is the cause of this double trigger in this patient? I think the cause of double trigger in this patient is flow asynchrony. Is it flow asynchrony? No, it is cycling asynchrony, because you have set a flow of 105 liters. So basically you are not giving any inspiratory time for these patients. This is a quite high inspiratory, quite high flow. So if you're keeping a flow very high, the inspiratory time will be dropped. The patient wants more inspiratory time, and that will lead to a triggering of another breath, and that can stack on each other. That is called double trigger. So in this patient, you actually come down on the flow. This is not the right way to manage, isn't it? So, what we are traditionally taught in management of ARDS is For oxygenation, you have to give FiO2 and give PEEP. And if you want to ventilate the patient, you have to increase the minute ventilation. So minute ventilation you can increase either by increasing the volume, tidal volume, or by increasing the respiratory rate. Most of the times we want to give a tidal volume of 6 ml per kg, probably 8 ml per kg at the best, not more than that. And it is right also. So all the studies, irrespective of whether ARDS or not, even in the patients with neurological illness, when you intubate, you want to target a tidal volume not more than 8 ml per ml. So when you want to wash out CO2, that's what we call bedside, you want to increase the respiratory rate. So for ventilation, you require respiratory rate and tidal volume. For oxygenation, we require FiO2 and PEEP. And we have to monitor the plateau pressures. We discussed about the driving pressures. So driving pressures are better rather than plateau pressures, because in plateau pressures are, again, you want to keep the plateau of plateau pressure around 30 probably. But if there is a chest wall issues, then the plateau pressure is going to mislead you. And driving, when you're looking into driving pressures, that thing is sorted out. So driving pressure is more important than plateau pressure. So if your driving pressures are less than 15, even if your plateau pressures are going to 35, that you should not worry about that, right? So oxygenation, ventilation, that's how we are taught, but it is not completely true. Sometimes your respiratory rate can also decide oxygenation, and sometimes your PEEP can also decide ventilation. We'll look into it, right? So we discussed about the setting of PEEP and how we use our driving pressures, and there is a meta-analysis, multiple studies which shown that driving pressure is the best way to go about it at this point of time. Now understand this concept of inspiratory time constant. Inspiratory time constant is nothing but the time required for the lung to get filled. It's one inspiratory time constant, 63% of the lung will be filled. Two inspiratory time constant, 86. Three inspiratory time constant, 95%. So our inspiratory time should be at least three inspiratory time constant. And inspiratory time constant will come by multiplying resistance to compliance. So if your lung compliance is low, the lung compliance is low, resistance is low, the inspiratory time constant will be low. For example, ARDS, the lung compliance will be low, resistance won't be high. So ARDS patients will have a small inspiratory time constant. So to fill the lungs of ARDS patients, you require a lesser inspiratory time. But just look into COPD. The resistance will be high, and usually patients with COPD will have a big lungs, so the compliance will be high. So inspiratory time constant will be high. So the time required to fill the lungs will be high. So in COPD patients, if you increase the respiratory rate too much, what you are doing is, by increasing the respiratory rate, you are bringing down the time for inspiration and expiration. Each respiratory cycle you are shorting down. So what happens is, you won't be filling the lungs, rather than you are just filling the dead space in the airway and whatever the dead space which is available before the alveoli and coming back. So rapid breathing in COPD will be a problem. So in COPD patients, you cannot keep increasing the respiratory rate to wash out CO2. That's not going to happen. In fact, patient will have a auto PEEP, and dynamic obstruction will be there. So that's why it is important to understand inspiratory time constant. So that's why we are trying to say that respiratory rate can also uh, lead to problems in oxygenation. So in COPD patients especially, you have to understand, again, you cannot go for a crazy respiratory rate to increase the minute ventilation. In fact, minute ventilation will not be increased by increasing the respiratory rate all the time. So you cannot, usually we do not go above 30 breaths per minute in patients. What about permissive hypercapnia? Again, this is the concept we always talk bedside. So if the patient with ARDS, there is some CO2 retention, and acute CO2 retention, every 10 increase in CO2 retention will drop the pH by 0.08. So if the baseline CO2 is 40 and the patient retained 30 of 30 mm of CO2, so it will be suddenly PCO2 will be 70, and each 10 will drop the pH by 0.08, so it will drop totally by 0.24. Suddenly your pH is 7.16. And if you look at 7.16 pH bedside in ABG, you are little worried, because acidosis has other problems. So what we call here, it is permissive hypercapnia. That is, when you are not able to really ventilate the patient, uh, don't don't go for a setting which will injure the lung rather than accept a situation where there could be little bit of retainment of CO2 with not so much of effect on hemodynamics or so till 7.15 is probably is acceptable pH where you can allow the CO2 to go high. So for example, you have a patient where you have set a tidal volume of 6 to 8 ml. Patient is already maxed out on respiration. Respiratory is 30, but despite of that, the patient is having CO2 retention. And when you're increasing the PEEP, then the driving pressures are going high. That means you cannot increase the PEEP anymore because lung is a not recruitable lung. You are just distending by increasing the PEEP. So you have maxed out on ventilatory settings, but you can always increase the tidal volume here so that you can wash out the CO2. So if you have given two options to increase the tidal volume and wash out the CO2, and option two of accepting the CO2 retention with little bit of acidosis, you should go for a second option. That is called permissive hypercapnia. But now this is a concept which is not which is again misapplied in the intensive care units, some intensive care units at least. So when we are talking about permissive hypercapnia, by default you are saying that the lung compliance is so poor and it is not a recruitable lung. So these are the patients who will be hypoxemic, who will be requiring very high FiO2 to maintain the PaO2 of at least 60. So if you are seeing a patient who is otherwise PaO2 is 200, but CO2 patient is retaining, that is some discordance, right? So what I'm trying to tell is all the CO2 retention in the patient is not to give a lung protective ventilation. Sometimes something else is going wrong because of which CO2 is getting retained. In such case, it has to be addressed. You cannot say permissive hypercapnia and leave. Especially there are some indications where your permissive hypercapnia thing won't work. Especially the patient is already also having AKA with metabolic acidosis, which is not uncommon, right? So it will complicate the situation. Patient with severe acidosis and underlying cardiac dysfunction. It's very common for the critical ill patients to have underlying cardiac disease or myocarditis. They can, in very acidotic environment, they can throw seizures. They can have a cardiac arrhythmia and cardiac arrest. Retention of PCO2 is associated with pulmonary vasoconstriction. So if the patient is already hypoxemic and you are putting the patient on a positive pressure ventilation, which puts a lot of load on the right ventricle. Ideally, it should not if you are giving an optimal PEEP. But for some reason your right ventricle is already stressed out, and the retention of CO2 will actually further worsen the RV pressures, shock will lead to more acidosis. So it's a vicious cycle. So permissive hypercapnia, you can discuss about permissive hypercapnia with all the rules applied. And if the patient is deteriorating, probably that is the point. Either you have to think about what are you missing, what are you doing something which is wrong, which is leading to CO2 retention, or probably it is the time where you have to consider options like VV ECMO because you are not able to handle this anymore. So it is not like permissive hypercapnia is harmless. The other approach is if your pH is really dropping, what you can do is you can give soda bicarb, so improve the pH and allow the CO2 to retain. But again, this is a vicious cycle. Whatever the soda bicarb you are going to give is going to convert into H2 and CO2, and that CO2 you have to anyway wash out. If you are not able to wash out, that will accumulate and that will drop the pH further, and your total pH is going to drop. So again, this is a vicious cycle. The reason why you are not able to wash out CO2 is because the lung is so bad, and now we by giving soda bicarb we are in a situation where you have to wash out more CO2. So it is a temporary stopgap measure. Probably you can buy some time and sort out the issues, but it is not like you can keep giving soda bicarb so that you can allow the CO2 to build up in these patients. So why it is important is one of the reason why patient can have a CO2 retention is airway problems like obstruction or bronchospasm, which are easy to manage, which is easy to diagnose. But sometimes patient can have a CO2 retention because of the decreased perfusion. So this we call it as dead space. So the pulmonary vessels are either thrombosed or compressed. So if you are giving a PEEP which is distending the lung, so higher PEEP will cause CO2 retention, higher PEEP than required. Small pulmonary thrombi, microthrombi, which are not uncommon, can lead to CO2 retention. If the cardiac output is low or RV is failing, that will lead to the CO2 retention. So how are you going to diagnose these things? You can use what's the CO2 gap, which is nothing but EtCO2 and PaCO2 gap. If it is more than 10, then there is a problem with pulmonary vasculature or right ventricle. So either there is a thrombus, or the pulmonary vasculature is getting compressed with a high PEEP which you are giving, or the RV is failing, or the patient's cardiac output is itself is very low. So these are the situations which you have to troubleshoot. So the EtCO2 and PaCO2 gap is very important. If both are rising, if PaCO2 and EtCO2 both are rising, then you know that the problem is with airway, and you have to deal with the airway. So let us look into some of the bedside scenarios. So when you're looking at the patient, you want to really sort out what is the problem. So the spinal level, people will go and see the ventilatory curves and try to diagnose some asynchrony, which may or may not require treatment in the first place. And if the patient is having bad asynchrony, what you do is you sedate the patient deeply, and this cycle is a vicious cycle. It keeps going on and on and on. So one of the way to sort out this issue bedside is to just do a good clinical examination. By clinical examination, I do not mean that you go with a stent and put the stent on the chest of all the patients and transmit pseudomonas from one patient to another patient, but just do a good clinical inspection. In respiratory system examination, the most important part of clinical examination is inspection. So you look at the patient, try to sort out why the patient is breathing heavy. Is it a difficulty in inspiration? Is it a difficulty in expression? Or is it a difficulty in both inspiration and expression? If it is a difficulty in expression, we all know that there is a problem with airway. So it is going to be probably bronchospasm. If there is a difficulty in inspiration, it is either because of the acidotic breathing which patient is having, or it is because of the decreased compliance. So once you think that it is decreased compliance, you want to see the movement of the chest wall bilaterally. Is it symmetrically decreased, or is it asymmetrically decreased? If it is symmetrically decreased, bilateral chest movement is symmetrically decreased, and patient is having difficulty in breathing, difficulty in inspiration, that means the lung compliance is bad. And bilaterally, if the lung compliance is bad, the reason is either the ARDS is worsening, or the patient has pulmonary edema. So you have to probably look into JVP or some other parameters to understand why there is a pulmonary edema or not. So if it is ARDS, probably then you have to assess whether the lung is more recruitable, whether you have to increase the PEEP, or is the lung already over distant, whether you have to decrease the PEEP is what you have to understand. And if the patient is having difficulty in inspiration, but then you see a chest wall movement is decreased only on one side, so then you are thinking about possibly a pneumothorax or possibly a collapse. This is easy to fix, right? So then you look at the trachea. If there is a mediastinal deviation to the other side, it is pneumothorax. Or probably you can do an auscultation or percussion also, if you really want to do in a intensive care unit. But you understand most of the problems can be sorted out by doing a simple clinical examinations, which are very easy to do and very quicker to do. So once you have a doubt of pneumothorax, probably you can do a percussion, or probably you can do a bedside ultrasound to really look into it in a focal way, rather than screening all the chest wall to understand what is happening where. So if there is a unilateral decrease in chest wall movements, it is either collapse, or pleural effusion, or pneumothorax, and that you can differentiate by looking at mediational shift or simple percussion bedside, or probably sometimes auscultating the patient. So this is how we are going to approach the patients in ICU easily with a simple clinical examination, and that will sort out most of the issues easily. Let us look into one of the case again. So the patient is put on pressure control ventilation with a pressure control of 15 above PEEP, and ventilator was delivering 300 ml volume, and suddenly it dropped to 180 ml. So there is a sudden drop in volume which you are able to deliver with the same amount of pressure, indicates that there is something happened which has increased the intrathoracic pressure. It could be because of the airways, or it could be because of something else like a worsening of ARDS, pulmonary edema, pneumothorax, or collapse. This worsening has happened in 2 hours, so we are not expecting uh, the ARDS to worsen that bad suddenly in 2 hours, but it can still happen. So these are all the considerations which we want to look into. There is another consideration, something like leak can also happen, and that is something which you want to look into. So by looking at the patient again following the same algorithm, by doing a good clinical examination, you can actually sort out what is the problem in this patient. So what you are seeing in this curve is you expect the area under curve in the inspiratory and expiratory limbs to be same, but you can see that the inspiratory area under curve under the inspiratory flow is more than expiratory. So some of the air is leaking somewhere. Even you can see that the in the volume time it is not reaching the baseline. In pressure time also you can see that there is a decrease in pressure. So basically this is the leak. So if the patient is intubated and is talking to you, that means the leak is at the level of ET curve. Okay, so leak can happen from endotracheal cough from the bronchopleural fistula to endotracheal cough to the circuit somewhere. Anywhere leak can happen, and that you have to, once you diagnose the patient with having some leak, you have to algorithmically see where is the leak coming from. So in this patient, if some patient is talking, it is very easy, making some sounds, gurgling sounds. You can see a lot of air bubbles coming from the oral cavity. Then you are probably looking at an endotracheal cuff leak. Sometimes, rarely, it could be tracheoesophageal fistula as well. So once the patient, you have intubated, you are managing the patient, and the FiO2 requirement has come down, you have done a good treatment for this patient, and once the FiO2 requirement comes down below 50 percentage or 40 percentage, that is the time where you want to wean the patient off. Doesn't mean that you have to completely uh, switch off the sedation. So you have to change the strategy. Probably you want definitely want the patient to have a respiratory effort. So you're not going to have a deep sedation. You are going to sedate the patient mildly. You can use propofol or you can use Dexmed in these patients, and put the patient on pressure support ventilation. And once you put the patient on pressure support ventilation, you look at the tidal volumes, how much tidal volumes they are generating, how comfortable they are. If the patient is comfortable breathing and patient is generating a tidal volume with at least 6 ml per kg with whatever pressure support you are giving, then you have to come down on pressure support slowly, and once you reach the pressure support of 5, that is the time you can take the patient out of the ventilator. So the problem again, um, is sometimes people are taken onto the pressure supports of 20-25. That actually tells that the patient is not ready for weaning. If someone is requiring a pressure support of 20 or 25, that's important to understand, because this high volumes which are delivered sometimes in the patients with pressure support can actually cause a diaphragmatic dysfunction. So that will actually delay the extubation. Another problem it is very common in patients who are switched back to pressure support is the rebound of agitation. Patients were deeply sedated before, and suddenly all the sedatives were taken off. So it's not like patient on low dose of propofol or fentanyl are not going to breathe on their own. Sedation is not a contraindication just because the patient is in the pressure support. So you can always use a small dose of fentanyl sometimes, Dexmed, or very small dose of propofol can also be used in these patients. And you taper the sedatives and analgesics rather than suddenly stopping them, leading to withdrawal symptoms. The other issue when we really face in these patients is sometimes with the patients with heart failure. So from the mandatory ventilation, the moment you switch him to pressure support, they keep going to heart failure again and again, and the treatment of heart failure has to be optimized in these patients. Before extubation, we check for any glottic edema. So we do something called cuff leak test. We deflate the cuff and auscultate, and we deflate the cuff or see how much is the leak. If it is more than 150 ml, we are expecting no glottic edema. Very crude way of looking into it. But once we extubate, then we see some patients getting deteriorated within few hours or a day and getting reintubated. And believe me, most of the times we label it for a possible glottic edema. It is, and we would have done the cuff leak test, and patient will have a good cuff leak also, but we label it as glottic edema. And the moment when you are reintubating, you will always see glottis which is erythematous or edematous, because patient was been intubated for very very long. So this is one of the bias which we have. There are few other things which we have to understand before labeling everything to glottic edema. One of the reason why patients can get reintubated is because of the opioid withdrawal, especially patients with a high fat or COPD patients who have accumulated fentanyl for long time. The moment you take the patient out of ventilator and stop fentanyl, it has a very short half life. You can actually see the opioid withdrawal symptoms with lot of tachypnea, tachycardia, a lot of sweating. Sometimes these patients can have MI also. So you would have shifted the patient in the morning. By the night, you can see the patient coming back to ICU, getting intubated, and he will again improve within a day or two. You will not understand what really happened to the patient in the ward. The other important reason why the patients get reintubated are especially the COPD patients. So when we are ventilating the patients, when you have taken the control over the patient, what you do is you forget about the patient's baseline illness, that the patient is a case of COPD. So for example, there is a case of COPD with baseline PCO2 of 60, and his bicarb has increased proportionally. For 20 of PCO2, the bicarb has increased to 6, so his basic bicarb was something around, for 20 of PCO2, the bicarb has increased by 14, so the basic bicarb is something around 40. So patient's baseline is 40 bicarb and 60 PCO2, and he got some critical illness because of which he got intubated, managed. But if you target for a near perfect ABG by the time of extubation, at the time of extubation, if he has a pH of 7.4 and PCO2 of 40 and bicarb of 24, that is a problem. So what happens is, the moment you extubate, the airway problem will come back, the patient will start retaining CO2, and it will go back to the baseline of 60. And bicarb will not jump from 24 to 40 in a day. It will take 2 or 3 days for the metabolic compensation to happen. So now what happens is, because the PCO2 is increased by 20 suddenly, the pH will drop by 0.16. So suddenly the pH will become 7.24, and the moment pH will become 7.24, patient will become tachypneic. And the moment the patient becomes tachypneic, the expiratory time will drop, and the moment the expiratory time will drop, a patient of emphysema will have a dynamic obstruction, and he will start retaining more and more CO2. He will kind of have an auto peep, and he will land up in exacerbation and get reintubated again. Again, when you manage the patient, patient will improve in 1 or 2 days, and you might do a same mistake again when extubating the patient. So this is an important situation where which we have to understand in managing the critical ill patients. So what we have discussed today is the basics of mechanical ventilation, including what is trigger, what is cycle, what is mode of ventilation, and using ideal body weight to set the tidal volumes. We try to discuss a little bit about driving pressures. We also discuss about permissive hypercapnia, and to importance of knowing contraindications for permissive hypercapnia and not labeling other reasons of hypercapnia as permissive hypercapnia. And we also try to understand that this conventional thinking that PEEP will only cause oxygenation. If you actually give an optimal PEEP, the lung should recruit. So you are basically increasing the volume of the lung, compliance of the lung, which should also help you in ventilating the lung. So at the same time, increasing the respiratory rate might not uh, might also cause hypoxia, because you are basically doing a dead space ventilation in patients with COPD with a high inspiratory time constant. If you increase the respiratory rate a lot, that will create a problem. Uh, the modes will not matter whether it is volume control or pressure control. Both the modes require thorough understanding of what you are basically doing. So if someone is saying that the patient was on volume control, he deteriorated, I came and switched him to pressure control, after that he's improved, then you have to understand that the person who is telling you is not understanding something which he should have understood. So the the mode of ventilation doesn't matter, except in very rare situations where also it is more about comfort rather than ventilatory mode changing the prognosis of the patient. And clinical examination is important. Just because you have an ultrasound, you can actually keep screening the same patient again and again and again. In ICUs, we listen to this thing that ultrasound is the stethoscope of a critical care physician. I always ask, if the patient is having a little bit of bronchospasm, will you be able to diagnose it using ultrasound probe? Probably using a stethoscope is easier, even though it is a little bit subjective. But again, the thing is, it is great to do all the interventions in ICU, but I personally believe it has to be minimalistic, it has to be very objective, and it has to be replicable. It's not like what you are saying will not cannot be confirmed by your colleague, and you really don't know who is right. So I being an ID physician, I like something which is very objective, which I can see and feel, uh, and something which can be done real time. Uh, so there are a lot of practical issues. You want to use ultrasound, but again you have an ultrasound for 15 patients, and someone will be getting line, someone will be using for something else. So you cannot always chase have an ultrasound and do it bedside. It is very important to have a clinical examination. Then you identify what is the possible cause, and then you use an ultrasound to confirm it rather than using ultrasound to diagnose the clinical situation. We'll be discussing more about ARDS. We'll discuss about phenotypes. We have already discussed about the sedation, analgesia, and neuromuscular blockade. Finally, I'm going to take you to the ID. You might be thinking why ID physician is discussing all this stuff, but you will eventually know why it is important for an ID physician to understand a little bit about critical care as well. Thank you very much.